Good evening, everyone. Respected Dr. Rohan Grover, sir, esteemed members of IADP, and dear doctors. We welcome you all once again to another episode of Learn from Our Master series organized by IADP. Crossing 90 webinars has truly been an incredible journey, and we sincerely thank each one of you for your continuous support, whether through our webinars or through our Instagram and Facebook platforms. Your positive feedback keeps us motivated and humbled. For those who are joining us with the first time today, a brief introduction. We are the International Association for Dental Practice Excellence, a platform dedicated to enhancing dental knowledge and clinical excellence. We strongly believe that quality education ensures predictable outcomes for dentists across all disciplines. Dentistry is ever evolving and continuous learning is the key to success. Through our webinars and workshops, we aim to guide and upgrade every dental professional's journey. Now, without further delay, let us begin today's session. Today's topic is rubber dam isolation in difficult clinical scenarios, from frustration to predictability. This insightful session will be delivered by Dr. Rohan Grover, sir, a renowned prosthodontist based in New Delhi. He completed his post-graduation from King George's Medical University in 2016. His clinical practice focuses on restorative, endodontic, and implant dentistry. His philosophy revolves around biomimetic principles with a strong emphasis on rubber dam isolation and adhesive techniques for long-term success. He is especially passionate about simplifying complex clinical procedures into practical, step by step protocols that can be easily implemented in everyday practice. It is truly an honor to have such an experienced clinician with us today. So, without wasting more time, I would like to invite Dr. Rohan Grover sir to today's discussion. Sir, welcome.
Thank you, Dr. Shri. Thank you so much. Hello, everyone. Good evening. I'm Dr. Rohan, and I thank you all for joining this webinar on a Sunday evening. So, I am very passionate about biomimetic and adhesive dentistry, and I'm looking forward to inspire you to start your rubber dam journey if you are not already using it. And if you have been using it, let's deal with some difficult scenarios. Okay. So, what are the goals of today's webinar? The goals are to simplify the use of rubber dam in everyday practice and learn how to deal with difficult and frustrating clinical scenarios. Because trust me, rubber dam sometimes can be very frustrating, especially in the beginning. Okay, so this picture which we are seeing here is from 1890. That is about 1.5 centuries old. So, what is the thing which we notice here? That every patient being treated in this clinic has a rubber dam, right? But the doctors are not wearing gloves because the gloves were introduced, regular use of gloves was introduced in dentistry 90 years later after rubber dam. So, even in that era, the benefits of isolating a tooth to obtain a dry working field free of salivary contamination was appreciated. So J.M. Prime in 1937 said that starting the daily use of rubber dam is the beginning of wisdom. When the rubber dam comes through the door, slipshod methods go out of the window, and it marks the beginning of better dentistry. So, firstly, we need to discuss some common misconceptions which are present among us doctors regarding rubber dam isolation. First is some people say that it takes a lot of time to isolate, and that they say it wastes a lot of time, and the patient gets fed up, the assistants get fed up, they themselves get fed up. But believe me, even if it takes 5 to 10 minutes to isolate a difficult case, you are going to make up that time easily because once the rubber dam is on, the patient is not talking. Okay, the patient is not spitting, he is not rinsing, you are not changing your cotton rolls, you're not shouting at your assistants, and you can just work in a peaceful and controlled environment. So it may take 1 minute, it may take 5 minutes, it may take 10 minutes, it doesn't matter. So what I would advise you is don't keep looking at the clock when you're doing your rubber dam isolation. Just get over with it, no matter how much time it takes, because that time is truly going to be made up later on during the procedure. Second misconception is cost, that it is costly. That is not true at all. A good, even if you're using the best armamentarium, good sheet, a rubber dam isolation is not going to cost you more than 40, $50. So it is just an initial investment of some good clamps, some good sheets, and good armamentarium. And after that, it's not costly at all. The real problem is in the lack of training and confidence because we are not taught rubber dam isolation in our colleges. So that is where the problem lies. And in some cases, we feel that the patient may deny. Yes, the patient sometimes can deny, but we can deal with that also, right? So, what kind of patient can deny a rubber dam isolation? There are some patients who are claustrophobic, who are have some psychosomatic issues, or maybe they are mouth breathers, but these constitute only 2 to 4% of the cases. In rest, all the other patients, it is very easy. And contrary to belief, patients do not find the use of rubber dam difficult. Trust me. So what is important is that we should explain to each and every patient briefly what we are going to do. Communication is very important because in some cases, especially if it is for the first time that the patient is going to experience this, it might just be a daunting experience for them. So if they are aware of what is going to happen, we can make them aware by showing them just a small picture of our previous procedure or small video. Then they are aware of what is going to happen in the next few minutes, and they will not be surprised. So rubber dam is mostly accepted by all the patients. So, like I said, the problem is in the inexperience and lack of training. So, when we start, the first 10 rubber dam isolations are not going to be easy. Your first and 10th is going to be different. Your 50th and 100th is going to be absolutely different. It is just a matter of practice. In beginning, we just have some fear, and this fear is coming from inexperience, not from incapability. So in the beginning, even if the things are not going right, the sheet is tearing, the clamps are flying off, the patient is getting a little nervous, please don't give up because it is going to happen. There is going to be some anxiety in the beginning, but you just have to be persistent. All right. So these are the difficult clinical scenarios which we see in our everyday practice. We'll discuss them one by one. In the beginning, it's very easy to fall into the temptation of skipping the rubber dam. Like we said, we'll skip in this case because it's a difficult case. But that's where we go downhill. We can't do that. In the beginning, we might skip, but later on, trust me, you will apply the rubber dam in each and every case because you will not feel like working without it. It is such a brilliant thing that you will not work without it once you have done a few number of cases. Okay, so why can there be a problem in applying a rubber dam or achieving a good isolation? Firstly, there may be some problem in the armamentarium we are using. Maybe our technique is not right, or maybe the scenario is very difficult. That is why we are here to discuss those difficult scenarios. But remember, isolation difficulty is not a reason to avoid rubber dam isolation. With some practice, we can achieve a good isolation in every case. So let's start with the right armamentarium. The first thing is a rubber dam sheet. Now there are various sheets available in the market, but I would advise you to go only for the good brands because once the sheet starts tearing, that is a very big disappointment and it hits our confidence. And then that is where we try to, skip the rubber dam isolation. So, what are the basic requirements for a sheet? The sheet should have good elasticity and it should not tear. It should have some good memory and it should return and adapt to the tooth nicely. All right. Some sheets are made with latex and some are made without latex. So, in only in cases of latex allergy, you can use the non-latex sheets. But in 95% of the cases, I would say 99%, non-late the latex sheets work well, all right? And these sheets come in various thickness, like thin, medium, heavy, extra heavy. Again, in 95% of cases, medium sheet works well. Only in a few cases, we need an extra heavy sheet or a very thin sheet. So the sheet should be thin enough so that it can be stretched over the bow of the clamp and it should pass through the contacts easily. If it is very thick, it will not pass through the contacts. So that could be a problem. Now, next important thing is the forceps. So what is the purpose of a rubber dam forceps? The only purpose is to hold the clamp, take it to the patient's tooth, and then remove it once the procedure is done. So there are different designs which are available. It depends on personal preference, which one you want to use. Like if you see in this picture, the first one, I really don't like that design because I started off with that design and the clamp used to get stuck while we are removing it. So the middle one is a really good design because it gives you good access, especially in the posterior region, in all regions of the oral cavity, and it's very easy to remove it once the clamp has been placed. And it's also very easy to remove the clamp in the end. Okay, next thing is the rubber dam punch. What is a punch? Punch is basically an instrument which has got a metal table in which there are 5 holes of different diameters. The biggest hole is used for making a punch for the tooth in which the clamp has to be put. The next size is used for any other molar or if a molar has to be clamped and it has already been prepped. So if the molar is slightly smaller, you use the 4 number hole. If it is a non-prepared molar on which you're going to put a clamp, you use the biggest one. Because when you have the biggest hole, you can easily pass the sheet over the bow and it will not tear. The number third hole is used when you are going to put a clamp on the premolar. And your premolar is the anchor tooth. The fourth size is used for all other premolars and canines, and the smallest one can be used for incisors. So, what problems can happen in a rubber dam punch? So, this here is the table on which there are 5 holes. So, if you see the first biggest hole, you will see a nick or on a small notch at the edge of the circle, and you will see a similar nick in the smallest one. There is also a nick in the third one. The fourth one and the second one are perfect circles. So once you are making the punch and if there is a nick already in the circle, you will not get a clean cut. We'll show you what that means. Also, the second problem is once we have done a rubber dam punching, there are a few rubber dam tags which are left inside this hole. So if we try to do the punch on top of this, the plunger doesn't go inside fully and we get a cut which is not clean. So what is the meaning of a clean or a unclean cut? So if you look at this slide, this is not something which you want. You want this small rubber dam tag to get separated along with your punch because once this happens you have to tear it off and that's where the problem starts. Worst case scenario, it just tears like this. So you can't expect a good isolation from a rubber dam hole which is like this. It will definitely tear. So here you can see 4 punches. The first and the fourth punch are very clean circles. So they are very easy to pass through the contacts. The second and the third are not so clean. So there are chances when you are adapting these, it's going to tear. Okay. So the punches have to be very clean. Your rubber dam punch has to be changed after some time if it has been overused or misused. Why misuse? Because when if we don't center the plunger over the metal plate properly and we plunge it, then it gets damaged. So after some time, you might need to change it. All right. Next, we come to the clamp selection. Now, the clamps can be classified in various ways. There are winged clamps. The first row, all the three clamps are the winged clamps. The second row, these are wingless clamps. So my preference in 95 to 98% of cases is to use a wingless clamp. A wingless clamp is very easy to use. Only there are a few conditions where I would opt to choose for a winged clamp. Okay, so do we need to, how do we remember which clamp has to be used for which tooth? Do we need to remember all the sizes or all the shapes? That's not true. You don't need to remember 30, 40, 50 clamp numbers, or you just, with some experience, you will realize that only with 7, 8 clamps, you can isolate every case. Okay. What you need to see is this red circle. Okay. These, so basically there are no specific molar and premolar clamps also. It all depends on the size of the tooth, and it all depends on the shape of this red circle. If this shape is coinciding with the cervical morphology of that tooth, then that's the right clamp. If that clamp is giving you a 4-point contact on the tooth, then that's the right clamp. All right. So we need to see these distances. Distance A should be coinciding with the mesiodistal dimension of the tooth, and distance B, which is also called as the jaw to jaw distance, should be coinciding with the labiolingual dimension of the tooth. It is as simple as that. So whenever you're starting a case, you have to look at the tooth. How is the shape of the tooth? Is it a large tooth? Is it a small tooth? Is it a squarish tooth? Is it a triangular tooth? You need to see all these things. And according to that, you select the clamp. Second consideration is whether the clamp is going to be passive or whether it is going to be active. So what is the difference in between the two clamps? An active clamp is going to go deep around the cervix, around the CEJ area and engage the tooth. And a passive clamp will have the jaws straighter and it will engage it a little just under the height of the contour of the tooth. So if there is a tooth which has got a good clinical height, good crown length, you can easily go for a passive clamp. But in scenarios where you see that the tooth is very short, if the tooth has been prepared, already prepared for a crown, if the tooth has very little crown structure, if the tooth is partially erupted, then you might have to go for an active clamp, which is going to go a little down and engage the tooth. All right. Okay. In this case, we can see the use of winged clamps. All right. So we just need to be a little careful that we don't use wing clamps when we are doing a class 2 restoration, because the wings can interfere with the positioning of our matrix ring, and that can be a problem. All right. We will not be able to get an ideal matrix ring position if we are using a wing clamp. So in such cases, we have to be very careful and we should always try to go for a wingless clamp. All right. So do we need to remember all these? Absolutely not. Only 5, 7, or maximum 10 clamps and you are sorted. All right. You just need to see the size of the tooth. So for example, in this tooth, this we have clamped a second molar. But which clamp is this? This is a premolar clamp. Since this is a small size tooth, we can go for a premolar clamp. And if there are 4 points of contact, then that's the right clamp. All right. These are some essential things which you need, without which your rubber dam isolation cannot be done. You need a good floss. You need some flossers. You need a good lubricating agent because it will allow your septa, your rubber dam sheet to pass through the contacts easily. All right. Please don't use Vaseline. Please don't use shaving cream. Use KY jelly, which is easily available. Okay. Now, how do we make holes for the rubber dam? This can be done by using a template. It can also be done by taking the sheet directly to the patient's quadrant, patient's mouth, and marking it over there. So these are the different templates which are available. They usually come along with the rubber dam sheets. My favorite is the pack dam, this green pack dam which you see here. The holes which are made with this pack dam are very accurate. It has got a very nice curvature, so it coincides with the arch form very well. These straight ones, they are not so accurate. All right, so either go for a pack dam or either mark it directly into the patient's mouth. Okay, in some cases we have to be a little careful, or we have to modify our punching technique. These are very, very important, and this can be a sign of a big frustration if we don't take this into account. Now, sometimes we have a missing tooth. So, if there is one missing tooth, leave space for two teeth. If there are two missing teeth, leave space for three teeth. That's the rule. You have to follow this rule. Okay, why? I will show you later. If there is a class 2 cavity, then we have to leave slightly extra space. Not like twice the amount of space, maybe like 1.5 times the space we have to leave. So a typical distance between two holes is around 6 millimeters. So if we are doing a class 2 cavity, let's say we can leave 8 or 9 millimeter. All right. If there is crowding in the teeth, then we have to reduce the spacing. If there is spacing in the teeth, then we increase the spacing in between the holes. Sometimes the tooth is rotated or not in the proper alignment, so we have to change the position of the hole according to that tooth. It's as simple as that. All right. So if you see this picture, you see in between the second and third molar, there is a big class 2 cavity which we have to restore. So there is a large interdental space in between the two teeth, and there is a deep class 2 cavity. If we don't leave extra space here, then what will happen is we will not be able to get a good rubber dam inversion. There will be fluid leakage here. There will be soft tissue protruding out from this space, and the isolation is going to fail here. Now there is a missing tooth here. Do we leave space for only one tooth? No, we mark two teeth and we don't punch two teeth. So what happens with that is the sheet nicely goes into the cervical area. If we leave space for only one tooth, then the sheet is stretched and there is always going to be some gap and fluid leakage. So always remember, for one teeth, leave space for two teeth. All right. Okay. Now there are different techniques of applying the rubber dam. We can put the clamp first. We can put the dam first. Dam first is mostly used for anterior teeth, and we can put the clamp and dam together. Now, regardless of the technique you are using, all the techniques work well. It all depends on the personal preference. Regardless of the technique, the first step is that we have to roughly arrange the rubber dam sheet or the septate like this on each contact area. That is the first starting point. All right. And then slowly we have to make sure that every septa goes inside the contact area. All right. Okay. So this is basically this. I have got stuck at this point so many times, and I have given up rubber dam isolation many times when I get stuck here. When I used to get stuck here, you get stuck here, you just banish your rubber dam equipment, you keep it inside, and it's lying there for 3 weeks, 4 weeks, or few months, and after some time you take it out, you get stuck here again, and you keep it back again. So it is very important to understand how you get from here to here. All right. So this technique is extremely important. If you understand this technique, rubber dam isolation becomes a breeze. Okay. So this is how we do it. Now, after arranging the septa, your assistant is going to stretch the sheet like this. Okay. This is the floss and this is the soft tissue which is visible after the sheet has been stretched. Now, our common tendency is to push the floss in the center. All right. This is the biggest mistake which we can make. We try to slam this sheet inside with the floss in the center, and that's when it tears. So, this is not how you have to do it. How you have to do it is you have to pass the floss against the tooth. First on one side, once you start passing or you just start applying some pressure against the tooth, the floss is going to carry the rubber dam sheet along with it. Our goal should never be to push the sheet inside. We just have to floss against the tooth. Okay, so we floss it, the floss goes inside, but the rubber dam sheet might not go inside yet. All right. So what we do is we make a loop now. We make a loop, we pass it on the other side. All right. And then in most of the cases, your sheet will go inside, but sometimes it will still not go. So this maneuver has to be sometimes performed 2 or 3 times. Don't feel disheartened. This will happen. With some practice, you will understand how to do it quickly. Okay. Now, after both the sides have gone inside, you just take the floss out from one side, not from the top, not from the occlusal, from the side, and the sheet just easily slips inside. Okay. Now, after we have done this, after we have made sure that all the septae have gone below the contact point, we are at this situation and our isolation is still not complete. What is the next step? The next step is very, very important to get good fluid control to prevent any leakage during the procedure, and that is called as rubber dam inversion. Rubber dam inversion is very simple. All right. What we have to do is we just have to take a plastic filling instrument and gently push the sheet inside the sulcus. And at the same time, we ask our assistant to blow some air with the three-way syringe. And the sheet starts going inside the sulcus. It hugs the tooth nicely, and there will be a very good seal. Okay. So once the rubber dam inversion is done, something like this will be visible. Okay. But still, our isolation is not complete. When we see our clamp, we will see some space around the clamp here. Okay. This space also needs to be fixed. So how we do that? That is called as rocking the clamp. Okay. Or we just lift the clamp. So we can see here, we have to stretch the sheet a little bit. We open up the clamp. We move it left, right. This is known as rocking the clamp. And when we place it back, the sheet has gone inside. Okay, it's very simple. So why is rubber dam inversion so important? Why is it stressed so much? Because if you see this case, this case I did long time back when I was not aware of the importance of inversion, and I thought let it be it, I can manage. So you can see that the sheet is not inverted here around the molar where I have to do the restoration. Okay, and in the middle of the procedure, what do we see here? We see blood. we see saliva, and that is going to tremendously impact our overall restoration. So this is not a good scenario. It should never be leaking like this. This is as good as not using a rubber dam. So inversion is very important. How does a good inversion look like? This is a good rubber dam inversion. So till the time you complete your restoration is going to look like this only, and there is not going to be any fluid or blood or tissue coming out from here. Okay. So in the beginning, it is not going to be easy, especially in cases where there is attrition, especially in cases where there are old restorations, especially in betel nut chewers, in patients with these habits. There is a lot of attrition. There are sharp edges. There are old restorations which have overhangs, sharp margins, and your rubber dam is going to get torn, torn away, torn apart like this. So it's okay. You need to understand why this is happening and how you can manage this. And just go for it again. All right. Sometimes it can get messy like this. It may bleed. It's okay. Sometimes it can get torn. Like you can see, there is a little bit of tear between the second and the second premolar and the first molar. It's not the end of the world. You don't have to do this rubber dam isolation again. You can just seal that tear with some Teflon. It's very easy. Just put some Teflon. It will also invert the sheet in that area. It will also prevent any fluid leakage. Okay. And sometimes why we are not getting a good rubber dam inversion, it might be because of this small speck of calculus. So imagine if this calculus is here, how is the rubber dam sheet going to go inside? So make sure you always do scaling first before you try to put on a rubber dam. This calculus should not be there. Okay. Okay. And now another important concept is known as the split dam. In some cases, you from the starting you cannot get absolute isolation. Okay. Why? Because there might be some old fillings, the teeth might be already prepared, there might be a lot of inflammation, there might be a lot of bleeding. So what we can do in such cases is we can just cut the septa in between, fold the sheet like this, and we can start working with a split dam. Now you can do so much here. You can do some gingivectomy. You can remove all the old restoration. All right. They're like, it's a great starting point. Okay. And once this tissue heals in the next appointment, you can go for complete isolation. Another example of split dam, like if in this quadrant you see there is a crown here, there is a faulty restoration, couple of faulty restorations again here, your rubber dam is not going to get inverted, not going to go inside these areas at all. So you will get stuck here. So what is the next step? Just cut the septa and convert it into a split dam. Once you have a split dam, you can easily remove the restorations. You can easily remove the caries, the overhangs. You can do gingivectomy. You can clear all that mess, and you can just put a fresh rubber dam. Okay. So a lot of times this is asked like, is it better to do a single tooth isolation or should we isolate a larger segment? In the beginning, we are always tempted to isolate only one tooth because we feel it's easy. It's not easy actually. It is easier to isolate a complete quadrant, okay? Because that will give you a fluid proof area. There will be no leakage. When we are doing a single tooth isolation, there are more chances of leakage. Okay. Another Another few advantages of multiple tooth isolation is that you get a bigger working area. Okay. You get better illumination. All right. You have also the opportunity to change your treatment plan in case you find some other findings. Is there some class 2 or there is some other problem? if you want to do the whole quadrant together, it's always better to do a full quadrant or a larger segment isolation. Okay. In certain cases, you can go for single tooth isolation, like if you are doing a single tooth root canal, I'm sorry, it might work here. It might work. It might work here. But imagine when you're trying to open this tooth for a root canal and you see a crack going into the marginal ridge, into this wall. Now, if you understand the importance of a pre-endodontic buildup, you would want to restore this first. So how do you restore it now with the single tooth isolation? So if there had been a complete isolation here, it would have been very easy to restore this. Now, in this case, I had to change my isolation just because there was a crack here. So it is better to go for a full quadrant isolation from the beginning only. Okay. But still, if you are going for a single tooth isolation, there might be some cases where you can't do the full quadrant isolations. So what happens is you will see that there is some gap here. And from this gap, while you're trying to do the restoration, some saliva is going to start pooling. Okay. And then you are in a mess. Okay. So if you are doing single tooth isolation, please seal it with liquid dam or gingival barrier as minimum amount as possible. Like if in this tooth, you can only see leakage coming from here or some soft tissue protruding out here, just seal that area. Okay. And another great way of adapting the sheet around the clamp is by passing a floss behind the bow of the clamp and then below the jaws of the clamp. All right, this also gives a very nice seal in this area. Okay. Now, the next big problem which we have to deal with is deep subgingival margins. Now, we need to understand that these three things here are going to be your best friends in almost every case. Floss ties, B4 clamps, and Teflon. Okay. So what is a floss tie? A floss tie or a floss ligature is it works like magic. Okay. It will give you such tremendous amount of retraction of the rubber dam sheet. Like if you see this lateral incisor, you see where the sheet is and you see where the sheet has gone in the centrals where we have to do the restoration. So in such cases where there is spacing between the teeth, it is very difficult to get rubber dam inversion without the use of floss ligatures. So always you have to master the technique to use floss ties. Okay. Another case in which we have to do deep restoration. Now we have applied the rubber dam the best we could. We have done some inversion also, but still we have not gained full access to the caries or to the margin. But as soon as we put floss ties here, we can see the whole cavity and we can do the restoration easily. Okay. Floss ties can be, they can be cut right here or they can be, they can be tied to the rubber dam frame. Both work well, no problem. Rubber dam, floss ties are actually a very versatile thing. You can use it in a variety of situations like this. In some cases, floss tie can even give you a complete isolation of that segment. You don't need a clamp here. All right. You can put a floss tie in an X form like this, and the area where you are working, where you need some extra retraction of the rubber dam sheet, if you feel that the caries is not going to be visible properly, you can't access the margin nicely, just put floss ties like this. Okay. These claustrophobic cavities here, it's very difficult to access these, but with floss tie, you can easily see them and clean them and fill them, right? So floss tie is a very essential skill when you have to do proper isolation. Okay, another case of deep margins. So how do we isolate such a scenario? It is always better to just do a little bit of gingivectomy first so that you can see most of the defect. Okay. And in such a case, in most cases, one technique is not going to be enough. You have to use adjuvant clamps, you might have to use Teflon, you might have to use floss ties, or you might have to do all of them. Okay. Like, how do we isolate such a tooth? So, this on the second molar, you see this is the primary clamp, primary anchor clamp. On the first molar, there is a winged clamp. Why do we choose a winged clamp here? Because the wings of this clamp are going to prevent the sheet from coming into the defect. But that is still not enough. Then we also need to put a floss tie. That is still not going to be enough. And in the end, we have to even pack some Teflon here. That gives us a complete isolation, and then we can start working. Okay. So slowly, you will understand these things, that you have to use these additional means of isolation. Okay. Okay. Another case of deep margins. Like if we are doing a class 2 cavity here, it is very difficult to get access to the margin just with rubber dam inversion. So either we can go for a floss tie, or we can use this wonderful clamp which is known as a B4 or a number 44 clamp. Okay. With this clamp, you can see in the photo on the left, you see how much of the tooth is visible. And once we put a B4 clamp, how much we can retract the sheet down, and we can gain very easy access to the margin. Okay. So this is a great technique when we are doing class 2 restorations. Okay. So what all do we see here? We have a B4 clamp. We also have some Teflon packed here. Okay, this will give us a very good seal in this area. Okay, now the next common scenario, maybe the most commonly observed problem in our clinics, is a class 5 cavity or a non-carious cervical lesion. Some people feel that rubber dam is not necessary for such cases, and some they say that it is a overkill to isolate such cases with a rubber dam, and they feel that Teflon is enough. Just by packing Teflon, you can do this restoration. But I don't feel that. With good rubber dam in isolation, and by properly using a B4 clamp, you can get excellent access to this defect. You can get excellent retraction of the gingiva. And like this restoration is so easy to do now. From here to here, you cannot do just with Teflon. It's impossible. Now, these class 5 defects, they come in various shapes and sizes, but the principles of isolation will remain same, almost same in every case. Always do a large segment isolation. When you're going to isolate such a tooth, please don't expect a single tooth isolation to work. It will not work because these B4 clamps are accessory clamps. These are not your primary anchor clamp. These are not such strong clamps. Okay, so you always need a primary molar anchor clamp, or on some other tooth which is going to hold the whole assembly together. And just for isolating this particular tooth, you can put a B4 clamp. Again, in this case, just do a little bit of gingivectomy, put a B4 clamp, and your defect is so easily visible. Okay. All right. These are two very difficult scenarios which we see. Two deep class 5 cavities. The first case, the top case, has a class 3 and a class 5 together and adjacent cavities. So you can see how much retraction we can achieve with B4 clamps. Now, that might not be enough. So we just need to pack some Teflon here. And then we can access the margins properly. This Teflon will prevent any blood or any fluid from coming into this area. Okay. Two deep class 5 cavities on central incisors. We put some floss tie, and after floss tie, we might also have to put a B4 clamp once again. Now, in this case, you can see a mistake here. We see some soft tissue protruding out in the third picture. Now, why this is happening is because the sheet is getting overstretched in this area. The sheet is stretched here also, the sheet is stretched here also. So, what we need to do in such cases, if there are two adjacent big defects, always keep a little more spacing between the holes. Okay, and then you will not see this soft tissue coming out, because if the soft tissue is protruding out, then you can also have some leakage over here. Okay. Okay, so if you have adjacent class 5 cavities here on a premolar and a molar, first we can just do the premolar with a single B4 clamp, restore this, remove this clamp, and go to the molar. For molar, in some cases, you will have to put two B4 clamps like this, and in the center, you will get a lot of working area, and then you can easily restore this tooth. Okay. Now, in some cases, you have to try a lot of things. Okay. Like if you see this in the second picture, we have used a butterfly clamp, like a 2-1-2 clamp, but that is not enough. It is not giving us the right retraction. We used a floss tie, but the floss tie is not giving us enough retraction either. It is still inside the defect. But a B4 clamp is again a true winner here. It gives us full access to the defect. So you need to try. Not one technique is going to work in every case. In deep class 5 defects, you can either use a B4 clamp, or you can use a floss tie, you can use butterfly clamps, you can use a modified B5 clamp, or you sometimes you have to use a combination of these. Okay. And these just remember that these B4 clamps are sometimes they are a little flimsy, they are not very stable. So you might need to stabilize them with some liquid damp or with some flowable composite. Okay, next difficult scenario which we deal with is isolation of upper and lower sevenths. Now, let's first discuss upper sevenths. What are the problems which we face when we are going to isolate or put a clamp on the upper second molar? First, the tooth might be buccally drifted, buccally tilted. Okay. If we try to place a clamp, it might not be stable. It might jump off. It might impinge the coronoid process. It might hurt the buccal fat pad. So all these things can happen. Okay. So what we need to remember is we should always use a small size clamp like a B1, B2 or B3 clamp for upper second molars. Okay. And in most cases, these teeth are going to have a deep distal cavity. Second problem which happens is that once we have exposed this cavity, once we have removed the decay, the sheet will tend to fall inside the defect. This is very common. So we need some adjuncts to keep the sheet away from falling into the defect. Like we can pack some Teflon. It's very easy. And then it can be easily restored with the saddle matrix. In some cases, we can be a little creative and we can use a burr or a wedge to prevent the sheet from coming into the defect. Coming on to the lower sevens. In lower sevens, if we are trying to restore a distal cavity with the saddle matrix can interfere with the bow of the clamp. So there is a special clamp If you see, this is a special clamp which is known as the distal clamp. The name of the clamp is distal clamp. Why? Because the bow is distal. It is more distal, so it will give you some space to do your restoration here. If there is a deep cavity on the second molar in the cervical area, what do we do now? If our clamp is placed here, how can we restore such a defect? So again, we have to be a little creative. What we do here is we take the clamp off from this tooth, we place the clamp on the next tooth, on the first molar, in a reverse direction. The bow is facing anteriorly, okay, and you have so much space to work, okay. Some cases you might just put an adjuvant like a B4 or 44 number clamp so that you can get better access to the defect. Now, how do we isolate anterior teeth? Most of the anterior teeth, and especially those anterior teeth which have very less crown structure remaining, or they have been broken down, they can be easily isolated with the help of these clamps which are known as butterfly clamps. Why they are known as butterfly clamps? Because they have these wings, they in the shape of a butterfly. So these are number 212, 212A, B5, B6. All these clamps can be used in such scenarios. Coming on to broken down or prepared posterior teeth. So if we see the second case, there is a tooth which has got a big caries. So we isolate the full quadrant. We place a primary molar clamp here, and with a B4 clamp, we have such an easy tooth to restore now. In the first picture, we have got a prepared tooth. This tooth had a crown. The crown came off, and then there is some caries which you need to restore first. So you are not getting good retraction, good isolation here. You are not getting complete access to the defect. So what we do is we just put an additional clamp here. This is a modified B5 clamp. Another example of using a modified B5 clamp. You can see that the defect is very close to the gingiva. In fact, it went subgingival here. So we can put a B5 clamp and we can easily gain access to this margin. So this is another example of isolation of upper second molar. You can see that the primary clamp has been placed on the third molar. In some scenarios, if you're lucky, you can place a clamp on the third molar also, especially if the patient has got excellent mouth opening. So in this case, you can see that how we use different clamps. In the third molar, we have put a B3 clamp because it's a small clamp, it fits very well on a triangular third molar. Then for the second molar, which needs a pre-endodontic buildup, we just place a B4 clamp. On the first molar, we place a modified B5 clamp. And once we have done the restoration pre-endodontic buildup of this tooth, the second molar, in the next sitting, we can just go ahead and do a single tooth isolation. If single tooth isolation works for you, then you can do a single tooth isolation also now. Because you have sealed this tooth properly, you have enough crown structure now, and you can put a W8A clamp. W8A is an excellent clamp for teeth which have been prepared or for teeth which have a small clinical crown height. Because A means active. It's an active clamp. The jaws will go deep inside, very close to the gums, and it will hold the tooth very firmly. Now, coming on to tooth preparation scenarios for veneers. Now, imagine if there is a case like this in which you have to restore and prepare 6 teeth for veneers. How much time is it's going to take to do this case? I would say without rubber dam isolation, if you need to do 6 restorations and 6 teeth preparation, it might take around 2-3 hours, this whole case. But if you just put a rubber dam here now, you can easily do the restorations and the teeth preparation in half the time. You just need to do an open dam technique. This is an open dam technique which we use for teeth preparation for veneers, because if you can't do a full complete isolation here. So we need to do an open dam technique or a split dam technique. Another case, if we see of tooth preparation for veneers, in the first two pictures we are seeing, this is the tooth preparation phase. So we have opened up the dam. We do all the preparations, and in the next sitting, once we have to do the bonding of veneers, we all know how critical the bonding is for veneers. There are so many things going on. There are so many steps to be followed for the meticulous bonding of a veneer. So in such a case, we can go for complete isolation. How do we do that? We put floss ties on each tooth and we gain proper access to the margin. Now you can do the etching, the bonding, the cementation, the cleanup very easily. Otherwise, without rubber dam, this can get really messy. Now, the role of isolation, onlays and partial indirect restorations. You can't do isolate. You can't do proper adhesive dentistry in such cases without isolation. It is not possible. I feel it's not possible to bond onlays and inlays without rubber dam. They are going to debond. If you are going to do two indirect restorations here, you can see how clean and dry field you can achieve, and all the steps again from etching, bonding, priming, cementation, and cleaning up all the excess is going to be super easy. There is hardly any excess, there is hardly anything left to be done after this. Now there is another special clamp which is known as the 2AD clamp. So what is the function of this 2AD clamp? Sometimes we don't have posterior teeth. So this 2AD clamp takes anchorage from the canine or the first, sometimes you can also put it on the first premolar. And it has got two metal extensions like this, which go backward. So now you can work on the posterior tooth. In the first case, if you see, there's a molar here which carries like in almost all surfaces, 360-degree caries. So if you have a clamp here and you have caries below that, how can you work here? So you can put a 2AD clamp here and you can just remove this clamp and the rubber dam stays retracted very well. Okay. Another tricky scenario can be working very close or just next to already existing crowns and bridges. So if we see this second premolar, it has got a mesial cavity, but next to it is a long span bridge. So what do we do? Now there are two options. Either we can just make a small cut here, we can open up the sheet here and fold it and convert it into a split dam. Or even better, what we can do is we just lift the sheet and we place it here. The sheet it just stays here. You lift it out of the contact, put it here, do your business here. Once the restoration is done, put the sheet back inside. It's very simple and you complete your restoration. So no need to take off the crowns and bridges and you can easily manage such situation. It's not very easy, but with some practice, you can do this. Okay. And sometimes you have to think out of the box also, because you will realize that every rubber dam isolation scenario will be slightly different from each other. No two situations are going to be absolutely similar. Let's see the first case. So what do we see here? We have used two butterfly, two 212 clamps on the posterior teeth. because this patient was only 7 or 8 years old, and these teeth are very small. None of the molar clamps were stable. So we use two anterior clamps on posterior teeth. Sometimes you need to do that. Sometimes you are working very close to the furcation area, or you, like we discussed earlier, also you might be having a tear in the rubber dam sheet. Just put some Teflon there, and the defect is sealed very nicely. The third case you see here, in this you cannot put a clamp posteriorly. Either the tooth is missing or there is an implant crown or some scenario. So and we have to do a post and core on this tooth, suppose. So what we do is we place our premolar clamp in a reverse direction. We can place the bow in the forward direction, and that gives you so much space to work here. Now imagine if this bow is here, how are you going to work here? So you place a B4 clamp here, but you place the anterior clamp in a reverse direction. Now it is very common to see this in deciduous teeth. There is going to be spacing in deciduous teeth. So what happens in spacing? The sheet tends to pop out. It is not going to stay inside. So what we can do with such scenarios is we can use wedges. We can use a plastic wedge. We can use a wooden wedge. We can use these stabilizing cords, which are known as widgets, to keep the rubber dam sheet inside, so that now if it is like this, it is not going to pop out at all. For example, if you see this case only has a small chip here. We need to do a small incisal edge repair. So we don't need to put any clamp now. We don't need to isolate a very big segment. You can see that the only two central incisors have been isolated, and the sheet just stays there, and you can easily do this repair. Sometimes a B4 clamp. These are bloody brilliant clamps. This is one of your best friends. Believe me, you can use this clamp in so many situations. Here you can isolate. You can put a B4 clamp to stabilize a band here to do a deep margin elevation. So you can see in how many ways you can use these clamps. Sometimes if you have a very deep margin, you might need to open up the flap, and this you can easily do in a split dam technique. And once the margin has been acquired, you can just do the rubber dam isolation again and restore it. So these are the different ways in which you can achieve good isolation. Start with basic techniques, and with some practice, maybe in 6 months, 1 year, you can reach here. Okay. Now we are nearing the end of this webinar, and I would like to ask you a question. And someone had asked me this, and it had left a big impact on me. And to end this webinar, I would like to ask you the same question. At the end of your career, what do you want to be called as? A rubber dam dentist or a cotton roll dentist? Okay, no offense, but this left a big impact on me, and maybe this pushed me in my rubber dam journey a lot. Okay, so these are two great books you should read: The Use of Rubber Dam in Endodontics and Posterior Direct Restoration. This covers rubber dam techniques very well. And if you have any doubt, any questions, if you are stuck in any scenario, you can mail me or message me, and I'll be more than happy to answer your questions. Thank you.
Thank you so much, sir. Thank you so much
Thank you,
for
Dr. Shetty.
sharing your valuable knowledge and expertise on managing rubber dam isolation in difficult clinical scenarios.
Thank you, Dr. Shetty.
I'm sure all of us are taking back practical insights that will help us transform frustration to predictability in our daily practice. Thanks to all the doctors for your patient listening and active participation. We hope this session has added confidence and clarity to your clinical approach. Once again, thank you so much, doctor. It was truly a
My
wonderful and informative session.
my pleasure. My pleasure. Are we
And
open to take any questions?
yeah,
Like if we have any questions, we can answer them.
yeah, sure. If anybody can unmute and you can ask.
Okay, let me just go through the chat. I just saw the chat. Okay, so someone has asked that how do you clamp a tooth which already has a crown? That's an excellent question. It's very difficult to do that, and you have to be very careful. You don't want to damage that crown. So there are few things which you can do here. Use a clamp which is very passive. Firstly, try to avoid clamping that tooth, but if you have to clamp it, try to use a clamp which is passive, which is slightly loose fitting, not very active. Otherwise, it's going to chip off the zirconia or the ceramic, whatever you have there. Also, you can use a soft clamp, which comes from the company Kerr. It's called as a soft clamp, so that will not put so much pressure. Also, there is another thing, these cashew-shaped silicone keys, which are known as cushies. You can place this on the jaws of your clamp, and then you can hold it. It basically it gives a cushion in between. You can just put some Teflon also there. There are multiple ways to provide a cushion in between, and but the main thing is try to avoid putting a clamp there, and even if you have to put it, please use a very soft clamp, like a passive clamp, not active. Making how to make a floss tie is a little difficult to show in this webinar. There are plenty of videos. If you want, I can make a video and I will upload it soon. And how to cut the septa? It is very easy to cut the septa. You just have to lift the septa out and cut it with the scissor. That's it. Yes, please, please, I forgot to tell this. I'm sorry, but please don't do any isolation case without adequate anesthesia. The patient is definitely going to feel everything what is happening. Okay, the patient is going to feel the pressure of the clamp. The patient is going to feel when you are flossing through. So adequate anesthesia is paramount. When you're doing a upper posterior segment, good infiltration anesthesia with articaine, buccal and lingual infiltration is going to be enough. But for the lower arch, what my preference is, I always give inferior alveolar block followed by buccal and lingual infiltration with articaine, and then the patient does not feel it. It's very important that the anesthesia is effective, because if the anesthesia is effective, and if you are messing up in the beginning, if your clamps are flying off, or if there is a tear, if your hands are trembling, if so many things go wrong in the beginning, if you're sweating, you should not panic. You should always stay confident. The patient will feel uncomfortable only if the patient sees that you are being uncomfortable. So even if things are going wrong, the patient is numb. He or she will not get to know what is happening. You just have to stay calm. Okay, only spray will never is never going to work. Okay, so you always have to give adequate amount of anesthesia.
Dr. Rohan, one question. If you
Yeah,
could please explain how to, or the use of clamps on previously prepared teeth or
yeah,
or teeth with small clinical crown height. You had mentioned the W8A clamps.
yeah.
I
W8A
found that
is
segment very interesting.
W8A is if you're stuck on an island, and if you have an option of having only one clamp, that is W8A. W8A is going to be one of your workhorses in everyday practice. Small critical crown height, damaged teeth. W8A is going to work in almost every. Sometimes you can even put W8A on a third molar, on a deciduous second molar. Also, it works.
So,
So
what is it about the what is the specific feature, or what helps the W8A, or just the use of the clamp selection for a previously prepared tooth? because
Yeah,
the crown, the height of contour is gone, the
height of the
proximal
contour
contacts
is
are gone, everything is gone.
absolutely. Absolutely. So that is why you need a clamp in which the jaws are apically pointed, apically directed, not straight. Straight is used when you have good height, you have a height of contour, so it just fits there. But once you have lost that, you need your jaws to go a little deeper. Sometimes they are also resting on your gums. You need to be a little careful with that, and you will get very good isolation with W8A.
And interproximally in prepared teeth, where the contacts are opened,
Yeah,
we achieve rubber dam inversion with the help of floss ligatures
you can. Yeah, you
and
can do.
Teflon tape.
Yeah, Teflon. You can pack Teflon. You can make a floss out of Teflon. You take a floss, you roll it, make a cord of Teflon, and just
Okay.
pack it there. Just pack it there.
That was very helpful. Thank you.
No problem. And
So
someone
what
has
is the
asked.
per sheet charge?
Sorry,
So what is the per sheet charge of the rubber dam?
per sheet rubber dam cost? Are you asking?
Sir, sir, for the patient, the paying capacity and all that.
I don't think it's a big problem because a rubber dam sheet, the best rubber dam sheet will cost you around 30-40 bucks. Is that a lot?
Okay.
If you're using a inferior one, that is around 10-15 bucks. That's it.
Okay, sir.
So it's not expensive at all. It's just a misconception. It's just a myth.
So, ठीक है, sir. Thank you.
No problem. So someone has asked about the rubber dam inversion. Rubber dam inversion is basically after the contact areas have been passed through, what we do is we take a flat plastic instrument and we just push the sheet inside the sulcus. The sheet goes inside the sulcus, it hugs the tooth. It hugs the tooth tightly, and it will give a very good hermetic seal over there. If the rubber dam is not inverted, be prepared that there is going to be some fluid leakage there. So rubber dam inversion is very important. In some cases where you are not able to get it, put a floss tie. Floss tie will also invert the rubber dam and will give you so much more retraction. Okay, so someone has asked, can we do the preparation without the dam and put it when doing the restoration and bonding? Uh, I would say there is not a very massive advantage of doing preparation under dam, but I like to do it because I like to do all the things under rubber dam now. So when you're doing a preparation for an onlay, just do the occlusal preparation first without the dam so that you have the clearance. Once you're sure you have got the 1.5 2 mm clearance, then put on the dam, then complete your preparation. Because for indirect restoration, your margins are always, most cases, it's going to be supragingival. Okay, because you're saving a lot of tooth structure there. So rubber dam, preparing under rubber dam is excellent. You can do a lot better preparation under rubber dam. Trust me. The sheets which I prefer to use are the Nick tone sheets. Nick tone medium sheets I use in 90% of my cases. MK rubber dam sheets are also very good. So I would advise only these 3 or 4 companies like Nick tone, MK, Sanctuary, and Isodam. Rest, I am not a fan of rest of the sheets.
Dr. Rohan, just one question. If you could please outline how you would achieve isolation and inversions in a posterior indirect restoration, like an
Okay.
onlay, which is an MOD or a DO, for example, where you need to achieve inversion on the between the two teeth to place your indirect restoration. I hope I'm being clear.
Yeah. That's right. So let's go back to the case. Let me just open up that case, please. One second. I'm sorry. Okay, here it is. Okay, so you need to study how many teeth you are going to isolate, how much space there is between the two teeth. All these things are very important. Now, if you see this, the 6 and the 7 have to be bonded with indirect restorations. There is a large interdental space here. So when you are punching the hole, first thing is you leave a little more space between 6 and 7. Okay, that is number one. Then you select a clamp which will not interfere with your bonding procedures. Okay, the clamp should be slightly smaller in size, yet adequate. It should adequately hold the sheet and the whole assembly there. But at the same time, it should be away from the margin of your restoration and it should not interfere with the bonding. Okay. Second thing is, if you see on this first molar, there is a floss tie. You can see the knot of the floss tie here. Without the floss tie, the sheet would have been jumping over the margin. So in most cases, you need to put a floss tie, and you also might need to put a super floss. This white thing which you see here is a super floss. This will help in the easy excess cleaning after the cementation is completed. I hope I'm clear with that.
Absolutely. Thank you very much. Thank you.
No problem. Do we have any other questions?
Just one more question, if you don't mind.
No problem. Please ask.
About the upper 7, the difficulty in or the clamp selection and clamp placement for the upper 7. I understood the distal clamp, but if you could please just explain how you worked around placing the matrix bands, the saddle
Okay.
matrices and all that for upper 7s. That was very interesting because
Yeah.
the our anchor to the tooth you're working on is
Yeah.
going to be the anchor clamp as well.
Yes. Yes. That is the challenge in upper 7, because the restoration is on the same tooth on which the clamp is placed.
Exactly.
So that is the challenge. That is the challenge. Sometimes, uh, I'll be very honest, there are few cases where you have to work without the rubber dam, and this is one of the scenario in some cases where I had to remove the rubber dam and do the restoration with the saddle matrix, because either the mouth opening was not that much or the access was not there along with the clamp. So this is a very good question. This can be a problem. This is in some cases you can have this problem, but when you have good access with a saddle matrix, you can get a proper seal here. And also, if you see, in most cases, you have to do a matrix in matrix technique. There is a
Yeah.
saddle matrix, then there is a matrix inside the matrix, and there is
Yes.
some Teflon. Okay. And in this case, what you have to do is you place the saddle matrix, you open up the clamp a little bit,
Okay.
and you put it back. So the clamp stabilizes the matrix back. It
Okay.
doesn't work every time, but in some cases it does. And if when you are not able to place a, a saddle matrix, like in this second scenario, you're not able to place it. So what you can do is you can just do a freehand restoration here. All right, there is enough space to do a freehand restoration. Just make sure that your margin is clear. The sheet is not coming inside. There is no fluid leakage inside coming inside, and that can be ensured with the help of packing Teflon here.
Thank you, doctor. That was very clear. Thank you.
No problem. Do we have any other question?
Sir, uh, how to make sure the tooth is not broken off with the force of the clamp?
The tooth will not break with the clamp force. The force is not that much.
Okay, so where should that clamp and the jaw end should be meeting? Is it on
So
the bone or on the tooth itself?
ideally it should be just below the height of the contour, but
Yeah.
some cases it goes below that also. In such cases, you need to make sure that you're not impinging too much on the gingiva, because if you're doing that, the patient will feel that that area has become very sore.
Yeah.
Sometimes you can also cause some recession if your clamp is not placed properly. Okay, so make sure that your clamp has not gone too much subgingival. Okay,
So it's on the tooth, it's resting on the tooth or on the bone.
it should never rest on the bone.
So it's
It
always
should
on.
rest. It can rest on the near the CEJ, near just at the root surface, but not on the bone.
Thank you, sir.
So if someone had also asked when we use a winged and a wingless clamp. Most cases you can use a wingless clamp. A winged clamp can be used when you need some extra retraction of the rubber dam sheet. Okay. If you have any other questions, you can message me. I'll be more than happy to answer. All right. Someone has also asked what is the 4.2. There are four beaks or jaws of any clamp. So if all the 4 points are contacting the tooth, two on each side, your clamp is going to be super stable. It's not going to move. Even if one is not contacting, you have a tripod configuration there, your clamp can move. And during the procedure, it can jump off, and that's a very bad scenario. So always, once you place the clamp, first, you visually see that there is 4 point contact. Second, you try to take off the clamp with a little bit of force with your forefinger or with any instrument or a tweezer. If it is not coming off, then you are good to go. Most of the clamps which I use are from KSK. KSK has excellent clamps. You can also use 14 clamps. And one set which I would definitely recommend everyone to have is B1 to B6 Brinker clamp set from Coltine Hygienic. It's very, very, very important to have that set. B1 to B6, you need all of them. Okay. So someone has asked how to ensure that the patient keeps the mouth open wide. Do you also put the bite block on the other side? And does the patient bite on the bow, challenging the durability of the clamp? Okay, so once what I do is I put the clamp. I just put the clamp, not the sheet, just the clamp. I'm testing how stable the clamp is, how well the fit is, how many points are contacting. And at the same time, I would also ask the patient to bite slightly. I would see at that time only whether the clamp is moving with the bite force of the patient. Sometimes it moves, most of the time, it will not move. And the clamp will never break that way, don't worry. But it can move. So if it is moving, you might need to go for a different clamp. So you should check that beforehand. Also, one very important thing I forgot to tell, before starting your rubber dam isolation, the first thing which you should do after giving local anesthesia is you should floss and check every contact. If your floss is going, your rubber dam sheet will go. If your floss is getting stuck, it is getting torn, your sheet will not go. It will just not go. If your floss is not going, how do you expect your sheet to go? So first you have to clear that area. There might be some calculus, there might be some sharp margin, there might be some old restoration, there could be a lot of things. You have to make sure that the floss is going. Worst case scenario, what you can do is you can use a flat plastic instrument and you can do a little bit of separation there if you are really stuck over there. Okay, but that should be the last resort. And the patient is generally, what I ask the patient to do is when I ask the patient to open wide, they open wide, and in between they can just close a little bit and they can actually rest on the jaw. And that's when they fall asleep. Most of the patients are asleep when they are under rubber dam.
So in case of small tooth height,
Yeah.
usually the clamp rests on the gingiva. Sometimes the clamp cannot displace the gingiva at the cervical region, and it gets rest on the gingival portion. So is it safe or is it wrong to do?
I would not say it's completely wrong. Like, it's the last resort you should opt for, that your tooth is resting on your clamp is resting on the gingiva. Ideally, it should not rest on the gingiva, because if it is resting on the gingiva, then it below that you also have bone over there, so it's actually resting on the bone. So not try not to take it so apical. In some cases, uh, what you can do is you clamp some other tooth. That is where a 2AD clamp or a brinker clamp, or you just clamp some other tooth, and on that tooth which has got less tooth structure, put a B4 clamp, which is a very soft clamp, which will not apply a lot of force. It cannot. Or just isolate that particular tooth with some Teflon or other means which we discussed. Try to avoid putting a clamp on such a tooth.
Okay, sir. Thank you.
Doctor, if you could please explain the unique clamp that was the 2AD clamp.
Yeah.
That was very innovative, and if you could please just explain that again.
Yeah, 2AD clamp. So 2AD clamp takes anchorage from a canine or a premolar. In most cases, it fits on the canine, and it has got two metal extensions which go in a backward direction. So it will keep the sheet down,
Okay.
and you can work on the last tooth in the arch where you cannot clamp that tooth. So you put the anchor clamp on the canine or the first premolar, and you can work on the molars with a 2AD clamp.
And how would we achieve inversion around the distal tooth that we intend to work on?
Yeah, so if when there are no adjacent teeth, that inversion can be a problem. So in such cases, you can pack Teflon, you make a Teflon floss, you pack Teflon, or you make a floss type. In most cases, these two things are going to work. Or just put a small clamp like a B4 clamp
On the distal tooth to be worked on.
on the distal tooth.
Okay, thank you.
You're welcome.
And doctor, if there is, if a person has got treated teeth with sharp edges of the occlusal surface, which might potentially tear the clamp while passage, do you smoothen out the sharp edges prior
Yeah,
to clamp placement, prior
yeah.
to dam placement?
Yes, that's a very good question, because you have to check that thing while passing the floss only. The floss is only going to start getting tone, and that is the red flag. You have to notice that your sheet will definitely get tone. So if there is old restoration, you can just smoothen that restoration. If the patient has got a lot of attrition and has got sharp edges, you can just use a tooth polisher like a stone at very low speed, and you can just polish that.
Thank you, doctor.
You're welcome. All right, Dr. Sherry.
Yes, doctor.
Yes. Can we conclude this webinar?
Yes.
All right. I would really thank everyone of you to be here on a late Sunday evening, and you have taken the first difficult step. You being here is that step, and I'm sure, like, if you take small steps from now, you can achieve a good rubber dam isolation in three to 6 months. You can easily do that.
Thank you so much, doctor. It was truly a wonderful and informative session, and we deeply appreciate the time you have dedicated to us. We also encourage everyone to check out and follow Sir's Instagram page to appreciate his clinical work. To stay updated on our upcoming webinars and workshops, do visit our website www.iadp.org and follow us on Instagram and Facebook. If you have missed any of our previous sessions, don't forget to visit our YouTube channel and subscribe as well. Thank you all once again and have a great night. Good night, all.
Good night, everyone.